and prolonged problematic methamphetamine use can be associated with neural damage, cognitive impairment, cardiovascular damage and stroke, dental problems that are related to grinding of teeth, and long-term effects of methamphetamine use can vary, but can be at times correlated with problematic sexual behavior and related increases in HIV and sexually transmitted infections. But this is data from Prevention Point Pittsburgh. This is our program data. People who were asked about past 30-day drug use over the past decade. Overall, the number of participants in the program and who have been surveyed has increased. So the orange line shows just the number of participants has increased. The pink line is people who report past 30-day cocaine use, and that's either powdered cocaine or crack. Both are included in that. And the green is people who report past 30-day methamphetamine use. This looks at percentages. So you can see from both of these that in Allegheny County, among people who use our program, we see a much higher rate, a much higher proportion of people who report cocaine use than methamphetamine use. Although methamphetamine use has gone up in the past from 2014 through 2018, we've seen increasing reports, and then it's kind of leveled off and perhaps dropped a little bit in the past couple of years. So what kind of harm reduction services do we provide for people who use stimulants? As I mentioned, Prevention Point has been distributing sterile injection equipment since 1995. This is probably the most critical service that we provide. It's something that people don't have access to in other ways. It's something that people through much of the state don't have access to. We actually only operate within the city of Pittsburgh, but we see people who come from not just other parts of the county, but other parts of the state to access our services because services are not available in other places. People who use stimulants may use them by injecting, by smoking, or by snorting. Reducing the need to share injection equipment is critical to reducing HIV, hepatitis C, endocarditis, and other soft tissue infections. People who inject crack particularly often inject much more frequently than with opioid injection, and so this dramatically increases the risk of injection-related infection, makes it even more critical that there's access to an adequate supply of sterile injection equipment. In 2001, when we started our overdose prevention project, we started, in addition to distributing educational materials on opioid overdose, we also provided education on stimulant overdose, although overdose is something of a misnomer. Overdose doesn't happen in exactly the same way as with opioids. Often what people refer to as a stimulant overdose is really just a bad reaction. We have for a number of years been distributing ascorbic acid as a safer substitute for organic substances that people often use when injecting crack, which include vinegar or lemon juice, which can introduce bacteria and often damage veins. In Europe, ascorbic acid is also distributed and widely used among people who use heroin because there's a little bit different formulation of heroin that people need to have a acidic substance to break down. But in the US, it's mainly used for crack injection. We've developed educational materials on safer crack injection, safer stimulant use, and safer smoking, which we've distributed for several years now. This is an example of some of the educational materials. This is downloadable from our website, which talks about what an overdose or a bad reaction from coke or meth might look like, symptoms, what are the risk factors, when is it important to call 911, what you can do to help people. In 2018, after many years of wanting to do this, we finally started also distributing safer smoking supplies. In part, this is to reach the folks who have been using our program for years, who also use stimulants. And in part, it was to try to reach the broader drug-using population who weren't using opioids but only use stimulants, who we really found that we weren't reaching. Smoking is less risky than injecting, so providing people with smoking supplies provides them with a less risky way to administer drugs. And access to smoking supplies reduces the need for people to share, and that reduces oral disease transmission. And this has become particularly critical this year with COVID, as people being able to have access to their own smoking equipment and not having to share reduces oral transmission of COVID. We started in 2016 distributing fentanyl test strips, and we provide specific information on how to use this technology when testing methamphetamine. There's a little bit different requirements. You have to use a much larger volume of water. And so we've been providing that kind of information to people along with the test strips themselves. When we look at, aside from the public health measures of providing sterile injection equipment, and again, when you look at the disease transmission that people face without access to sterile equipment, in 2020, with our understanding of public health at this point, it is just completely ridiculous that in Pennsylvania, Philadelphia, and Pittsburgh are the only places where people can legally access this kind of equipment. When we look beyond those kind of specific public health measures to other types of interventions to help people address problematic stimulant use, I look to Seattle as a place where they are developing cutting-edge interventions. A project called Yes to Drug User Health did a survey of people who use stimulants and asked them what kind of interventions they thought would be useful for them, and a large proportion of people reported the need for stimulant substitution therapy. This is not something that's been well researched. For stimulants, it's well researched for opioids. We've had methadone and buprenorphine for years, and we know that these are the most effective types of treatment for opioid use disorder by far and away. So it makes sense to look at what kinds of substitution therapy can be developed for methamphetamine and cocaine use. So in addition to the need for increased access to syringe service programs in Pennsylvania, which are critical to reducing the spread of HIV, hepatitis, soft tissue infections, syringe service programs also can offer a critical connection for people who use stimulants to access healthcare and other services, fentanyl tests, safer smoking supplies, and other harm reduction services. I mentioned that in Seattle they have a pilot project where they're trying to increase the research base for substitution therapy for stimulant use, and they are really looking to Canada, to British Columbia, where they've developed a program that they call Safe Supply, where doctors are able to prescribe not just opioids as substitution so that people don't have to rely on the unknown opioid supply that often contains deadly fentanyl, but that doctors can also prescribe benzodiazepines and stimulants for people who use those drugs so that they don't have to worry about either fentanyl in their drug supply, or even there are things that have been found in the drug supply like ground mortar and all kinds of other things that create harm to people. But the one thing that I'd like to talk about a little bit more broadly, so much of what has been presented at this conference and that we're seeing in general when we look at problems of stimulant use focuses on the supply of the drug. And I feel like we really need to look at the lessons that we've learned when we look at opioid use in the United States and in Pennsylvania, where we started out with a focus on restricting the supply of prescription opioids, which created a huge problem in increased heroin overdose deaths and then fentanyl overdose deaths. And what we've seen historically is that when you focus on reducing the supply, and that is so much what has been talked about, is how to reduce prescribing of stimulants and how to interrupt the illicit drug supply, that typically when that is the primary approach, what you see is that people shift from one drug to another, typically all too often to a more dangerous version of that drug or a more dangerous drug altogether. So with opioids, we've seen people move from prescription opioids, where at least people knew what the dose they were taking, to heroin and then fentanyl. And if we look at stimulant use in the United States and the drug supply, we saw a big crackdown on home kitchen labs where people were manufacturing methamphetamine, followed by a huge influx of stronger, more dangerous methamphetamine from drug cartels in Mexico. So we see that this strategy has really increased the negative consequences exponentially. We can see with COVID-19 that we have had a severe overdose crisis for years, and this has made the overdose crisis much worse. Border closures have caused major disruptions in the drug supply, increasing the need to cut the existing supply with substances such as fentanyl or benzodiazepines. Social distancing requirements have reduced the capacity and reach of life-saving harm reduction programs. More people are having to use their drugs alone with no one to respond if they overdose. These are all problems that have existed all along, but that have just been exacerbated by the COVID pandemic. I think that one of the critical issues as we look at how to effectively develop interventions is that nobody seems to be asking people who use drugs themselves. I won't say nobody. There's some great drug researchers out there who have been doing this for years, but it's critical that we ask people who use drugs about why they're using drugs. We look at, there's a quote, new drug that we're seeing increasing use of, and the first thing we do is think about how do we reduce access to that drug, rather than asking people, why are you using this drug? Is it because it's the only drug you have access to? Is it because this drug is preferable to you over other drugs?
It's okay.
So I think it's really critical that we ask people about what they need and what they need in terms of interventions. So I see there's a red stage light. Should I be wrapping up now, or should I continue more? I'm asking the moderator for a little guidance here. Okay. So yeah, in closing, I would say that I think that rather than just assuming that we know how to address this problem because we have not been effective in addressing drug-related harms overall in recent decades, that we really need to focus on asking the people who we're trying to provide interventions to about what it is that they need.
And our next presenter up is Nelson Polite. Mr. Polite, if you could please unmute your microphone. Yes,
Is it unmuted?
we can hear you. Would you like me to advance your slides
Okay,
or?
you can hear me? Um, yeah, you can do that. Yes,
Okay.
that's fine. So
Yes.
we're ready? Okay. Yeah, can you just stay right there at the title? Because I'm actually going to start with the title a little bit. But anyhow, I'm Nelson Polite, and I'm glad I had an opportunity to present here today. I see that the presenters prior to me were able to talk, a lot about the stimulants. So I will kind of skip that part. Um, the only thing that I will add is, as the last presenter did say about asking the client the question about what they need in terms of help in relationship to their drug use. I think that's very important. I also had an opportunity to talk to a client, and she was actually a opiate user, but relapsed on stimulants. And I asked her the reason why, and she said because that's what was available to her, and also she didn't want to go and relapse and start the drug of her choice because she felt as though that was a more difficult road to go down. So she also mentioned, which I thought was kind of interesting, that it appeared as though stimulant use would have a more of a calming effect on the females, women, in opposed to the men. They tended to be a little bit more aggressive with their use. So stay right at that slide, because I'm going to move to the next section, area, topic, point, is the undeserved sector of the population. And this population I want to focus on is the African American population in particular. And I want to go back into history with this, because we have a long trail of with this situation in terms of Africans coming to this country. We came here in 1619, and we came here as indentured servants in Jamestown. And indentured servants just simply means that you work for the first 27 years of your life free, and then you get your so-called freedom. From that point, we went into chattel slavery for 252 years of free labor. And then after that point, it was in 1863, Abraham Lincoln, Emancipation Proclamation. After he passed that, the African Americans were so-called free, and we got a pushback from that and went into a period of Jim Crow and Black Code laws for the next 92 years, which took us up to 1964 civil rights bills. So that's just a little of the history, which basically kind of really put us in a very difficult situation in every sector of our society. And of course, it definitely had an effect on our drug and alcohol use. So I'm saying that as the title mentions, the same storm, different boat. You know, in terms of the African American, that storm was, I likened it to a Category 5 hurricane, in opposed to some other communities. And obviously we came here on a completely different boat and not the Mayflower. The next slide. This is just my information in terms of my history working with drug and alcohol, and also the criminal justice system now, Department of Corrections. So, next slide. I wanted to present this visual. Pennsylvania, those who are incarcerated. As you can see, especially on the slide on the right, that African Americans make up 11% of the population in the state of Pennsylvania, but yet we are 46% of those who are incarcerated in prison. And this actually started back in 1863. As I mentioned, the Emancipation Proclamation, part of the pushback was they began to have these vagrancy laws, because Africans were free but with no resources. So and that's really actually when it started in terms of the disproportionate incarceration of Black people. And that just continues today, as you can see, because the situation really, the reason why I went back into history, has never really been reconciled. Next slide. A lot of this material was already reviewed in earlier presenters, but one of 4 Pennsylvania families struggle with drug and alcohol abuse. And then the rates of substance abuse are so high in Pennsylvania that in 2018, the state ranked 10th in the nation's drug use. So we're pretty high up there. Next slide. Barriers. Are barriers to treatment and to be successful. Obviously, as there's drug and alcohol, substance abuse, most times what I've found is it's just polydrug use, drug and alcohol, cocaine, marijuana, poverty, especially those who are coming out of the prison system. Most times their money was depleted when they went in, and they were in a poverty restricted situation prior to their incarceration. Went inside the prison, served their time for a period of time, made a little bit of money, and most of the time it's just enough for bus fare to get to their location to get home. So that continues to be an issue. I work at a halfway house center, and when they come out of the state prison, most of them do not have a place to go, which is one of the reasons why the house was set up. So they're homeless until they can find a way and find housing, proper housing to go to. Most people feel marginalized in the community based on their drug and alcohol use, feel marginalized, or coming out of prison, committing a crime. They do not have a tendency to blend into the community. It's very difficult for them to do that. They have various abilities. I have a guy now who's a sex offender. He's had seizures early on when he was younger, and he now has a third grade reading level and has a very difficult time in comprehension. Some are more educated and have more abilities, but sometimes that can still cause an issue. Single parenthood, most of these parents are mothers with children, and they tend to struggle. There are some men, more men than what there used to be. I will say that since COVID-19, March of this year, I've seen an increase in women in particular getting pregnant, and which puts more of a burden on their already compromised situation. And untreated childhood trauma. This is an area where it's going to take a lot of work in terms of therapy, and most of them are unaware of the type of work that they have to do. In this particular area, they're unaware of their particular issues. And it doesn't really have to be a real so-called major traumatic situation that is, because in my situation, it was just that a grandparent had passed, and the grandparent happened to be my nurturer, and I was age 13, and I felt as though when the grandparent passed, the rug was kind of pulled out from underneath me, and that was a very tragic situation. So it may be a natural occurrence, but nevertheless, it impacts individuals as they move forward into adulthood. And most times it's unlikely that they even know how it shows up into their lives. Not everybody's the same, modularization, and so we need to treat them and find out the uniqueness about their particular situation, because especially guys coming out of prison, most times they feel as though they're just a number, and but they feel much better when you really focus on their particular needs. Next slide. Yeah, okay. Intersexuality. This definition, a framework for conceptualizing a person, a group, a people, or a social problem as affected by a number of discriminations and disadvantages. It takes into account people's overlapping identities and experiences in order to understand the complexity of the prejudice they face. As you can see, this is puts us in a position to look at the whole person, their culture, their age, their personality, their gender, their race, their mental health issues. Taking all of this into account is extremely important, and it gets to the individualization of presenting a treatment plan that will work for that particular individual. I think that's a challenge with society, and also a challenge, especially with the counselor slash therapist, psychiatrist, physician, is to treat the individual and take all of these things into consideration. Next slide. And finally, we have their needs. What needs to be done? As I mentioned, that intersectionality is extremely important and a vital part of the treatment planning. Those who are coming out of prison, in particular, or drug addicts, alcoholics coming out of treatment, they have some health needs that need to be addressed, and that's certainly one of the things that they do. We recommend a physical examination first. Education sometimes is limited. Start with to obtaining their GED, and then some of them have the ability to increase their education and move forward. Socially, this is a real big issue, because those who are drug and alcohol in recovery, and also those who are coming out of the prison system, have a tendency to isolate, and they just stay with their own particular group. And most times that does not fare well with them, because isolation a lot of times leads to denial of their situation, and then may cause some other problems. Spirituality, hopefully they can see that there is something greater than themselves, a power greater than themselves, something to anchor them and to put them in a position to be a whole person, something to center them. Some folks have never been centered, haven't had that type of family situation, and they need to create that in their recovery. I talked earlier about the trauma-informed care, to once again, to have the case manager and the outpatient therapist expose and identify some of the issues, because in most times they get drug and alcohol free, but they're blindsided by their trauma issues. Case management is one of the most important things for them to stick with. I would suggest for them to do that for at least 6 to 12 months. We see a lot now that sees psychiatric help and medication, co-occurring disorders. We see I saw an uptick of marijuana medical card use, especially since COVID. We encourage them to get employment, and from there housing, and then transportation. So is extremely important. And lastly, the more support a client has, the likelihood of their success, for them to be successful, will be the better. It will be the best outcome for them. I think that will do it. I see my time is up. So thank you.
Thank you very much, Mr. Polite. That was very valuable information, and it definitely heightened my awareness. Next up is Dr. Alan Weisman Ward. Mr. Ward, would you like me to advance your slides? Oh, you're still muted. Excellent.
You can hear me okay?
Yes.
All right, fantastic. Thank you to the previous speakers. I appreciate it, Alice and Nelson. My name is Alon Weissman-Ward. I'm a physician. I provide substance use disorder treatment in upstate New York and also do for Crouse Hospital, and also provide gender affirming hormone treatment with a company called Plume Health. That's a telehealth based company. And Tanisha, yeah, if you don't mind advancing the slides, that would be fantastic.
Dr. Weissman-Ward, we're hearing that your microphone is kind of low. Is there a way that you can get a little closer to your microphone?
Yeah, I can put it. How's now?
Speak for me.
Can you hear me okay?
I can hear you. I don't know if is everyone else here.
I'm going to take the video off so you're not seeing my face so close.
Okay.
How about now?
That sounds good to me.
Okay, fantastic. All right, so let me just repeat what I said. Thank you very much, Allison and Nelson, for your previous talks. My name is Alon Weissman-Ward. I'm a physician, family medicine and addiction medicine board certified. I practice substance use disorder treatment here in upstate New York with Crouse Hospital, and I also provide gender affirming hormone treatment for a company called Plume Health, which is one of the first digital trans health companies in the country. So thank you very much for having me. For me, I'm going to talk specifically about transgender and non-binary folks in treatment services. And why this is so important is that there's a huge gap in care for folks. As it stands now, there are that I'm aware of, only two trans-specific programs for substance use disorders or addiction. One is in the beautiful city of Philadelphia. It's the Morris Home, which is a halfway house specifically for GNC, gender nonconforming and trans folks. And the other one is based all the way on the other West Coast in San Francisco. That's an inpatient substance use disorder track for trans feminine or trans women. So I think what we see pretty clearly is that we don't get enough training on what it means to be transgender and non-binary. And so my goal is to sort of bring that to you today. So first and foremost, talk about what is gender. We all experience it every day. It's a very personal, unique, complex identity that relates to culture, it relates to bodies, and it relates to the world that we're in. Next slide, please. And let's see if you can see it. Oh, this slide is not showing up. I apologize. This next slide basically gives you all of the different labels that we can use in the gender variant community. And there's many, there's hundreds, right? It really depends on what community you identify with. Some folks use the term transgendered. Some folks use the term non-binary, gender non-conforming, gender queer. The most important thing is just to echo what Allison Nelson said, is to ask your patient, hey, how do you identify your gender? And from there, you take folks' lead. All right, next slide, please. I think it's really important that we all understand what gender dysphoria is. And it's basically feeling like your mind and body don't fit. They're not aligned. And I would argue that probably everybody has experienced this to some degree. If you were assigned male at birth and still assigned male, I'm sure at some point in your life, although it's still along the same gender spectrum, you have thought that you weren't masculine enough or manly enough, like I've got to do this to man up, right? And on the same side, folks who are assigned female at birth and still identify as female have undoubtedly experienced, oh, I'm not womanly enough if I don't have long hair or makeup, etc., if I don't like to do these things. So at some point, everybody's experienced gender dysphoria. I think the big deal for folks who are trans is that it causes an excessive amount of distress and pain to the point where folks won't even leave their house, right? Next page, please, or next slide. So why should we identify transgender patients? I think the same reason why we're going to identify any of our patients and what substances they're using, so we can provide them with the best care that we can give to them. And I think what's really important, another gap that we're seeing, next slide please, is that there is not a lot of data and there are not a lot of studies around folks who identify as transgender and non-binary. In fact, if you see, we really only have one huge study, and this was done 5 years ago. They should be in the midst of getting a new one up, that surveyed 28,000 trans-identified folks in the United States. What this did is this looked at, asked people mental health questions, it asked people substance abuse questions, it asked people employment questions, you said mental health, asked about suicide attempts, and it also asked about, hey, what was it like growing up to be trans? And to date, this is the biggest study we have. There's a scattering of other small studies about around transgender and non-gender conforming people, but there surely is a gap in here. Next slide. So what we see, I think, is one of the most important things is that growing up as transgender and non-gender conforming is really, really tough. And thank you, Nelson, for talking about intersectionality, because the stress that gets placed on you when you're not only transgender, but now you're talking about Black, Indigenous, Latina, like the stress is that much more increased. As you're seeing, 50% of folks, youth, they're harassed, right? I think we all have a pretty good idea that the more stress you experience as a youngster, right, the more likely you are to have a substance use disorder or to have an addiction. Next slide, please. And here we can clearly see this with the data that they collected 5 years ago with a survey. And what we can see is that rates, with the exception of tobacco, rates of substance use disorder are higher in the transgender, non-gender conforming population. Unfortunately, this study did not portion out whether or not for illicit substances, whether that was cocaine, methamphetamine, Molly, heroin, which is to me unfortunate, and it's one of the recommendations I've made to them in the future is to really be able to separate this out so we have a better idea about what's going on. But again, you can see the rates 2 to 3 times higher with marijuana, non-medical prescription use, and again, this can include benzos, opiates, Adderall. They didn't separate that out, and then illicit substances. Next slide, please. And I think what you see in this slide is, again, to talk about intersectionality, and something we're aware of. When trans folks, non-binary folks are engaged in things like prostitution, selling drugs, or selling hormones, or providing procedures for trans folks because they can't get the procedures that they want necessarily legally, these folks are going to have a higher rate of substance use disorders. And I would also like to point out that these folks are traditionally, more often than not, Black and Indigenous and Latina. So again, you're seeing the intersectionality of underemployed or unemployed trans and race or ethnicity playing a role in your substance use disorders. And we're seeing the rates are sky high. And again, just to reiterate, while we have these higher rates of use in the trans and non-gender conforming community, we do not have the programs to support, I believe, to adequately support this population. Next page, please. Again, this is just to reiterate, how does a trans identity increase your rate or chances of having a substance use disorder? One, I talked about increase in adverse childhood events. 2, the minority stress theory, which applies to all Black and Indigenous people also, that look, the more stress that you're under in this world, or the less privilege you have, the more likely you are to use substances. I think with that, we also see an increased rate of mental illness. In the study that they did in 2015, they saw, I believe it was 36% of folks who responded had attempted suicide, right? That's 36% of the folks, which to me is mind-boggling. And then again, you see increased traumatic life events. In 2020, we had more African-American transgender women killed than any other year so far. We're not doing a good enough job with this. And then lastly, I think it's socialization, right? Where are the safe places where trans, non-gender conforming folks can go? It's usually the gay bars or the lesbian bars, right? And what happens in bars? Drinking, alcohol, cocaine, methamphetamine, Molly. And then also you see like the big celebrations, the pride parades. I would ask anybody in any major city to not to that to look out for the ads for alcohol. They're there. They're not going to be there. I've never seen one Pride where there wasn't a huge ad for Smirnoff or one of those vodkas. And I think also you look at the Prides and they've been used as an excuse by both straight, gay, cis, trans as a way to party. I don't know if anybody's ever been to San Francisco Pride, but quite frankly, for me, I've never seen more people under the influence and actually needing ambulances, right? So there's a lot of substance use going on in the community, and what can we do in our specific treatment centers? We can get trained, right? And I would say more than like a 10-minute training, but making sure the staff is aware of the proper language to use. And if you don't know the language to use, again, ask. Making sure that your forms actually say, have more than one gender marker on it, right? It's not just male, female. Making sure you give people the chance to put down their correct pronouns. And then I would say like hiring folks, right? If we want to treat underserved communities, we have to have people who look like us within these work environments, right? So I'm going to leave it at that because I think there's 5 minutes left. Thank you.
Thank you all for your participation. If there are any questions, submit them to the Q&A box so that we're able to address them. Doesn't look like any questions are coming in. There's been some comments. Dr. Alan, there's a question asking, are there any resources available for transgendered clients? And one additional question for Dr. Alan. How can we make our space friendlier to transgender folks? Thank you. Mrs. Bell, why are there not more prevention programs throughout the state?
I guess that's a question for me. The reason that there are not more syringe service programs throughout the state is because the possession of sterile injection equipment or any ejection equipment or any drug paraphernalia continues to be illegal in Pennsylvania under the state drug control law. These laws were implemented, in states across the United States decades ago. They've never been shown to decrease drug use, and they clearly increase drug-related problems as they, if people who are injecting drugs always had easy access to sterile injection equipment, it would reduce many of the problems related.
Thank you. And it looks like it's 11 o'clock and our participants will have to go back to the plenary sessions. Thank you very much.